In this video, we'll talk about substance use disorders. With intoxication and withdrawal, as long as you know one, you should be able to figure out the other because they'll be opposites of each other. So just keep that in mind as you're studying intoxication versus withdrawal. First, let's talk about alcohol use disorder. The first line treatment for this is Naltrexone. This works by being a new opioid antagonist, and it helps with alcohol use disorder by decreasing craving. Another first line treatment is Acamprosate, and this is a glutamate modulator. Disulfiram can also help with alcohol use disorder, but what happens is when they take disulfiram and then drink alcohol, it makes them throw up. So this only works for people who are abstinent because it's very easy for people to just not take the disulfiram and then go drink. So always pick Naltrexone or Acamprosate. It's also important to know the presentation of alcohol withdrawals. So within like the first 6 hours to the first day of 24 hours, patients will first be like anxious, they might have insomnia, they might start to have tremors, start sweating, palpitations. And then from like the 12 to 48 hour mark is when they can have seizures usually, and you'll treat that with Benzos. And then delirium tremens occurs from hours 48 to 96. And this is when they'll start having visual hallucinations. Benzos are used for severe withdrawal. Keep in mind, people with alcohol use disorder are more likely to have liver conditions. So when you're picking a benzo to treat their withdrawal, make sure it's one of the OTLs, so outside the liver benzos, so like lorazepam or oxazepam, because those won't be metabolized by the liver and thus will be effective in treating their alcohol withdrawal. Next, we have marijuana or cannabis THC. So with intoxication, a great buzzword is conjunctival injection. Their eyes will always be red. They'll have increased appetite, dry mouth. They can have tachycardia, slower reflexes, and just slower reaction time. For cocaine, intoxication is going to increase your sympathetic nervous system. So you'll have sweating, mydriasis, so dilated pupils, tachycardia, hypertension, chest pain. They can have tactile hallucinations as well. A few other buzzwords to see if it's cocaine toxicity is that they might have erythema of the nasal mucosa, decreased appetite, weight loss. Sometimes cocaine toxicity can be similar to a manic episode, but they'll be elevated, irritable, hyperactive, maybe agitated. But the difference is if they're manic is that they won't have all of these like increased sympathetic nervous system responses as well. PCP intoxication is very classic, presenting with severe agitation, violent behaviors. The other big buzzword is the nystagmus that can occur, and sometimes it's difficult to decide between PCP versus cocaine, but cocaine again will have the sympathetic vital signs that are deranged, like hypertensive, tachycardic. They should also give you other clues with cocaine, like the nasal erythema that we talked about earlier. Treatment for PCP overdose is giving them benzos to control their agitation, and if they ask mechanism of action, PCP is an NMDA receptor antagonist. With amphetamine intoxication, you're also going to have increase in sympathetic response. So dilated pupils, tachycardia, sweating, teeth grinding is something that's different. Another big thing is excoriations due to skin picking. That's a big buzzword, tooth decay. And then sometimes it can be difficult between amphetamines and PCP to differentiate between them because they're also both violent. But the intoxication with amphetamines lasts longer than PCP. Next, we have benzos. So benzo overdose will lead to like respiratory depression, altered mental status, hypotension, bradycardia, and that'll be even worse if they are co-ingesting it with alcohol. It's very important to know that abrupt cessation of benzodiazepines is potentially life-threatening. For benzo overdose, you want to give flumazenil. Another good thing to know is normal pupil size is 3 millimeters, so sometimes the vignette won't say meiosis or mydriasis. They'll just say pupils are 2 millimeters or pupils are 5 millimeters, and you're just supposed to know if that's dilated or constricted. So for example, with opioid or heroin intoxication, they're going to have meiosis. Pupils are usually 2 millimeters, respiratory depression, constipation, symptoms like that. And the treatment right away is naloxone for opioid overdose. And then the long-term maintenance therapy is naltrexone, which is also used for alcohol use disorder that we talked about earlier. Methadone is another long-term maintenance therapy, especially if you're pregnant. Buprenorphine is an opioid partial agonist that is also used for opioid use disorder and pain management. It's important to know that the urine drug screen won't detect semisynthetic or synthetic opioids, such as hydrocodone, hydromorphine, oxycodone, and methadone. And with opioids, it's very important to check your electronic medical records to see if patients have been prescribed them recently, if they should be out of it by now, because patients can like prescription hop between providers, so you always want to check the OR system before prescribing them more opioids. Opioid withdrawal will look like muscle spasms, diarrhea, piloerection, and yawning and pupil dilation. So again, the withdrawal and intoxications are opposites of each other. For smoking cessation, first line is Varenicline, and a couple fun facts to know about this is that it's excreted by the kidney. It can actually increase suicidal ideation, so always monitor patients for suicidality, and also it can cause nightmares. Bupropion is another medication that can help with smoking cessation, but remember that it's contraindicated in people who have seizures and or if they're bulimic and they vomit a lot, because that'll cause electrolyte derangements that will lower the seizure threshold further. With hallucinogens, you're going to have visual hallucinations. There's not really any withdrawal symptoms you have to worry about. When someone is taking high-dose steroids and for a longer period of time, that can also induce mood or psychotic symptoms as well. And sometimes it can also lead to aggression, gynecomastia, decreased testicular size, and sperm count. It'll also cause low FSH, LH, and testosterone. So just a couple things to look out for. Withdrawal of steroids can lead to decreased libido and impotence. In general, anti-cholinergic toxicity, for example with TCAs, that is going to be increasing your sympathetic activity again. So you're going to present with mydriasis, tachycardia, dry skin, urinary retention, symptoms like that.